So I'll try to keep this interactive as much as possible. And if you have any questions, I'd like to stop here and then answer that question. And because these presentations become boring, but just for the sake of completion and your boards, you will see similar questions, something related to this. Just mute you guys. Okay. So, why is it not working? Okay. So as you can see, this is a cartoon showing subendothelium inactive platelets. In the first A section, the platelets are just running through the blood. Then at some point in time, there is a change in the endothelial surface. Can you see the mouse or not?
Yep, we can see it.
Okay, good. And when the endothelium gets exposed or denuded, it gives off these receptors which are attached to the platelet. So the platelet adheres to these receptors. When it adheres to these receptors, it leads to something called activation. The shape of the platelet changes and the platelet gets degranulated. When it gets degranulated, which is called platelet activation, then it starts aggregating. And then the clotting cascade starts at that time, and that leads to more aggregation and stabilization of clot. And eventually it retracts. So let's go over the different receptors here. So the first receptor that is getting activated is GP1B. And there's also alpha-2 beta-1, but the GP1B is what you need to remember. Thrombin and ADP are very aggressive substances that leads to this adhesion. When they lead to this adhesion, then the activation occurs. As a result of that, more ADP gets secreted and fibrinogen gets secreted. The thromboxane A2 gets secreted, and that leads to more exposure of these platelets. As you can see, the von Willebrand factor is the endothelial surface receptor, while the GP1B, glycoprotein 1B, is the platelet receptor, which gets adhered to that. It also gets adhered to the collagen. This is collagen here, and then fibronectin. But this is the receptor that we try to work on through our antiplatelet agents, which are P2Y12 inhibitors. And once it goes into the aggregation phase, then the glycoprotein 2B inhibitors come into being. So as you can see here, this is glycoprotein 2B3A, which is causing the aggregation. So these two steps are blocked by our medications are called antiplatelets, and I will be going over them. I'll not be going over this stabilization and clot formation, which is activated or mediated by fibrinogen and can be blocked by the fibrinogen activators or things like that. Okay. So the first one that comes up is the aspirin. Aspirin is the prototype antiplatelet. And their aspirin has been there for a very long time. We know that thromboxane A2 gets inhibited by this, which is causing what step? What step is it causing? This is causing the first adhesion step. And as a result of activation, it is getting released. So the first two steps are mediated by this. Aspirin also has a non-responding rate, although we do not clinically take this into account. So just remember that there is an aspirin non-responder. It will not be the answer on the boards, but it's one of the phenomena that is out there. So what we found that initially, very long time ago, in 2000s and 1990s, that aspirin was protective in diabetic patients and in non-diabetic patients. And we found that patients who were on aspirin, they did much better than the patients who were not on aspirin in terms of death as well as MI. Then came this group of inhibitors, GP2B3A. Around the same time, the P2Y12 inhibitor came into being as well. In 1998, Clopidogrel came. And then actually before that was ticlodipine, which was taken off the market. But Clopidogrel came around the same time, which were more potent platelet inhibitors. And we found that GP2B3A inhibitors did very well in patients with diabetes and non-ST elevation MI. So in that phase of cardiology, I still remember people were getting a lot of these GP2B3A inhibitors, and then they were having brain bleeds because of that. As you can see, the meta-analysis showed that it's better compared to placebo. Now coming towards the ADP receptor, we're talking about this ADP receptor. The ADP receptor is what we call P2Y12 receptor. And this is the receptor that we block through our medication. There's also a subtype P2X1. It also has some research-based blocking agents. P2Y1 is another one. These are the different subtypes. But Clopidogrel is the one, as well as Prasugrel and Ticagrelor block this P2Y12 receptor, which helps actually in sustained aggregation and secretion. So like I mentioned initially, the ticlodipine came into being, and they found that ticlodipine had much higher risk of major bleeding, neutropenia, thrombocytopenia. So it was taken off market early on. Again, another meta-analysis done by Dr. Bhatt. Then came the big trial, the PCI cure. And you all need to remember this trial. This was the first trial that showed that Clopidogrel and aspirin was better than aspirin alone. And there was about a 4% reduction in the outcomes, which was CV death and MI, or MI. This was Salim Yusuf's study, pretty major study. As you can see, there are only 1,300 patients, which are very different from today's trials where which are mega trials with 10,000s of patients. So about 4% difference. And remember this number. So Clopidogrel and aspirin, even with them, you have an annual risk, actually not annual risk, this is about 400 days. Yeah, annual risk of about 8.8% of CV death or MI. Regardless, whatever you do, you will still have this outcome with Clopidogrel. After this, again, this is the other trial. There are only two trials you need to remember about Plavix or Clopidogrel. One is PCI cure and the other one is Credo. This one was also another, and this was the intention to treat analysis again, 8% with Clopidogrel, and placebo was like 11 to 12%. Before I go forward, I just want to talk about the Clopidogrel. So Clopidogrel is a prodrug. You guys know what prodrug is? Prodrug is something that goes into the liver from the stomach and changes into an active metabolite, and then it works. Same thing happens with Prasugrel, another one. It has rapid absorption, quicker absorption than Clopidogrel, but it's again a prodrug. Now for Prasugrel, the trial that you need to remember, the only one trial that you need to remember, although there's a newer trial that I will mention later, is Triton-TIMI 38 or TIMI 38. And this was the trial on the basis of which people started doing this. You can see this here, not to give in the patients who have prior stroke or TIA. And then this was hypothesis generating that if the age is greater than 75, not to give in those patients, but younger patients, and if the weight is less than 60 kilograms. They found there was harm in that. But this again, this is the trial is not powered for these outcomes, and these were just subgroup analysis. And recently, actually, they found that it works okay with older age and the younger age. There was no difference, as well as the weight. There was no difference. But the stroke, because of this finding, they put a black box warning on the Prasugrel not to give this in patients with prior stroke. Now, this could be a hemorrhagic stroke or ischemic stroke, doesn't matter. So what we found in 2000s is that if you intensify the platelet agent, you have less events. As you can see here, where is the Triton? 28. Again, so I'll show the results later. Again, in case of then the Ticagrelor came in 2009, around 2009, and we found that this is actually not a prodrug. So the step through the liver is not needed. So it just goes and becomes an active compound right away, and then it's used. It's in the blood in 2 hours, and in 6 hours, it's at the peak. So what we found, and this is interesting, you can see this, right? Plato trial. The only trial to remember for Ticagrelor is Plato trial. So PCI cure and Credo for the Plavix, Triton 38 or TIMI 38 for the Prasugrel, and Plato for Ticagrelor. Just for the board's sake, just to mention this, so they also found that the patients who underwent CABG had higher bleeding in the Triton 38. So they might sometimes ask this on the boards that what type of bleeding goes up. So it's the CABG related bleeding. Non-CABG related bleeding was not different in that. So in Triton 38, what are they comparing against? The arm is now Clopidogrel is the standard of care. In Plato, they are comparing against Clopidogrel. Now you see, this is weird, right? So the cumulative incidence is around 9.8%, although they are including what in it? Stroke in it. They did not include stroke in the previous studies. So when you include the stroke, now there's a difference. There's a difference of about how much percent? 1.9%. So like 2%. Between aspirin and Plavix, the difference was 4%. Between Clopidogrel and Ticag, about a couple of percent in 1 year. When they looked at the MI, they found a significant difference, as well as the death. So this is why this is the only study or trial that actually was powered enough to look at the cardiovascular death. And Ticagrelor is the only drug that has demonstrated independently a difference in mortality. So that's why Ticagrelor became such a word of mouth and everybody started using it right away, because it impacted the mortality. Now, when you look at this, they also found most of the times what you find is if you take care of the ischemic risk, what happens that your bleeding goes up. But what they found was that the non-CABG related bleeding was actually higher in Ticag. It's the opposite, right? While the CABG related bleeding was not significantly different between both. Again, a good sign. So good marketing, and because of that, it just went ballistic, and Ticagrelor started being used everywhere. although there are still places which are not reimbursing it very well. So as in our state, and you see that all the time, that people are leaving on Plavix, but the guidelines at the moment have Prasugrel or Ticagrelor as class 1, as the first agent. And Plavix is a second agent, okay? Always remember this. Plavix is not preferable. Now, onset of, so this is again Dr. Bhatt. So these slides are from Dr. Bhatt's lecture, so that's why you're seeing a lot of his references. But he recently worked on this, this reversal agent. At the moment, we don't have any reversal agent commercially available. If you are on Ticag or Plavix, the only thing that might help is platelets, but it's not going to help if you're bleeding acutely. We recently had a patient where I gave Ticagrelor and patient started having GI bleed on the table, which was pretty interesting to see. She already had stents placed, but if we did not have the stents placed, maybe we could have reversed the Ticagrelor. As you can see, this reversal agent is called what? PB 2452 something. So GI bleeding is a big problem in these patients, and it's important to assess the need for antiplatelet therapy before bringing the patient to the cath lab. History of ulcer or ulcer complication, that's important to know. Some people, I personally like to test actually H. pylori in these patients so that they can get treated, and then you can go ahead and do the antiplatelet agent. If you cannot avoid it, then you need to put the patient on PPI. Okay, very important to remember this. If you have initially, if you had any risk factor like older age, GERD symptoms, or corticosteroid use, you just put on PPI regardless in these patients. And this is, I think this is an area of improvement. We don't really ask this question. And as you can see, when they start putting the PPIs on, there was a concern that the omeprazole had an interaction with the Plavix and Clopidogrel, and that led to decrease in bioavailability, although they eventually found that on a clinical level, on a population level, it does not impact that much. So it's fine, but at the moment, most times when you have somebody on omeprazole, you will receive a pharmacy call saying that switch the omeprazole to Protonix or something else. So pantoprazole does not have that interaction as significant as the omeprazole has. As you can see, the Cogent trial was done again by Dr. Bhatt, and which found that if you have on PPI, there's a decreased risk of bleeding and primary GI bleeding in these patients. So think about that when you are putting somebody on. Anyway, so bleeding reduction is an important thing to think about because it is directly linked with mortality. Radial access, minimizing the DAP duration to 1 year. If you are on a NOAC, trying to limit the use of aspirin, using of PPI, lowest effective dose of aspirin, and preferential use of Clopidogrel over Prasugrel or Ticagrelor, different strategies you can use to decrease the bleeding. So I'm going to go forward. The next thing in the mind of an interventionalist is always what to do about stent thrombosis. So all of these medicines actually improve or decrease the risk of stent thrombosis. The more potent the medication is, like Prasugrel, the most potent one, you will see the decreased risk of stent thrombosis. The least potent is Clopidogrel, so you'll see more stent thrombosis with that medication. Now, people are really scared of stent thrombosis. Stent thrombosis is not that common, especially in the era of the drug-eluting stents that we are using now, which are second-generation drug-eluting stents. As you can see, and this comes on the boards as well, that the second-generation drug-eluting stents compared to the bare metal stents have decreased restenosis and decreased stent thrombosis. Initially, we found that there was higher risk of um, stent restenosis, high risk of stent thrombosis in the drug-eluting stents compared to bare metal stents with decrease in stent restenosis. But we found that if you decrease or make the stent strut smaller in size, there was actually decrease in stent thrombosis as well. So I'm gonna skip this, that we have different scores to evaluate who needs longer DAPT for 2 years. One of them is DAPT score, one of them is precise DAPT, which takes into account um, the risk of bleeding. And you can go to this website, precise DAPT score, to look at it. The shorter DAPT is better, or the longer DAPT is better. A score of less than 25 will give you a longer DAPT. Okay, now coming to the bivalirudin. So bivalirudin is also it's an anti-clotting agent, which we use. It's a reversible binding, and it's specific to thrombin. Remember these words. It comes in the boards. Okay, so the boards ask you, especially what is reversible agent and what is not. So Ticagrelor is a reversible agent. Clopidogrel is not a reversible agent. Aspirin is not a reversible, it's an irreversible agent. So bivalirudin is a reversible agent. And you're saying something? Hello? Somebody. And before I go over bivalirudin, I want to go over the Cangrelor first. So let me just go quickly to Cangrelor. Yeah. So the trials with Cangrelor in it are all called Champion, something Champion. So there are 3 of those trials. Champion Phoenix is the first trial where what they did was they used Cangrelor, bolus, and infusion. And as you can see now, this is a more recent trial. So the number is like 10,000. These are called mega trials. And then they gave Plavix 600 or Clopidogrel 600 milligrams after they stopped the infusion, after 2 to 4 hours. Remember these words. So they asked this question, where should you give the Ticagrelor? You can give Ticagrelor anywhere in the middle. But for the Clopidogrel, because in the trial, that's how they tested, it needs to be given after the Cangrelor infusion is finished. So that's what they did. And depending on the physician, they gave 600 or 300 milligrams in the placebo arm. And these patients had all the stable angina, STEMIs, all of them. And what they found is that the death, MI, stent thrombosis risk was less in Cangrelor. So Cangrelor was also better than Clopidogrel. The stent thrombosis risk is also much lower. So really perfect drug for interventionalists. However, it's very expensive. So it's not being used that widely yet. Now, this also was looked at for the non-cabbage bleeding, and they found there was no difference in cabbage bleeding and non-cabbage bleeding. But as you can see, the numbers are like 9 and 6, very small numbers. When they looked at the major bleeding, there was a significant difference. This is acute major bleeding, which includes much more people. As you can see, 235 and 139. But numerically, you can see Cangrelor has much more bleeding than the Clopidogrel. The stent thrombosis risk was clearly low, and it was especially low if you had ACS. So many places have started using it as a default in ACS patients. Patients come to the table and it started on the Cangrelor infusion. And it also helps because, some patients do not have that active GI, and you can just get it directly into the system. So because of its rapid onset, people who were with Ticagrelor, they came up with this, okay, why not we crush the Ticagrelor? Because when you crush the drug, it increases the surface area and then it can be absorbed quicker. So they did this Cantic trial where they crushed the Ticagrelor 180 milligrams, and then they crushed Ticagrelor with Cangrelor, and they gave it in during the infusion. They stopped the infusion at 2 hours because after 2 hours the Ticagrelor is working, and they found that the PRUs, which is platelet reactive units, this is placebo. For the Cangrelor, as you can see, it drops drastically within 5 minutes. So when you are doing the angiogram or putting a stent in, which is usually around 30 minutes, end of the PCI, if you are using just you're not using Cangrelor, you're just using crushed Ticagrelor, the platelet reactive units, which you want below 220, somewhere here, 200, below this number, takes about an hour to drop below that. But if you're giving Cangrelor, it's right down there. So because of this, if I'm going really fast, in my case, sometimes what I do is I give a little bit of tirofiban IC intracoronary so that there are no platelet agents acting at that time. When it goes to like 1 hour, 2 hours, kind of almost similar. That's what they're showing. All right, so there are newer agents that have come up, like elerusumab, that has shown to help these patients as well. Anyway, I'll talk about bivalirudin and GP2B3 inhibitors in a different talk, so that's why I stopped here. But as you can see, these are kind of last 25 years of pharmacotherapy, where we started with aspirin initially, but then we added these dual antiplatelet agents, which really helped with the stenting and keeping the stent open. Clopidogrel was the first one, but then Prasugrel and Ticagrelor actually improved on that. Pival and GP2B inhibitors were initially used a lot, but then they were taken off because heparin is cheap and it serves you that's almost the same results as the bivalirudin and GP2B3A in several trials now. Heat PCI and matrix trials are the major ones that you need to remember. And then Cangrelor is the new one that is new kid on the block. Where to use that? Patients who are going for surgery, cabbage, I would use it. Patients who cannot tolerate PO, have some GI discomfort, or patients who are intubated, I would use Cangrelor in those cases. So 3 cases clinically I would use it. Now, I purposefully left the time for you to ask any questions, and you can unmute yourself and ask questions now. Do you have any questions? Mostly
thanks, Dr. Qureshi. So I know that Dr. Alonso was working on the
loading, yeah,
the loading trial. Is there any, or the registry or upstream, is there any data on that yet? Do we know?
So yes, so there is data as far as
for Ticagrelor,
the PRU, yeah, Ticagrelor. More of the actually Clopidogrel is available, that if you load 600 milligrams or 300 milligrams, what happens to the platelet reactivity units. And actually there's a clinical study that actually looked at what is the benefit of loading somebody beforehand. And they found that there was much decreased risk of stent thrombosis. So the real benefit is the stent thrombosis, the acute stent thrombosis that we see. As soon as we put the stent in, you know, like I mentioned, there are aspirin non-responders. So if you don't have a platelet activity, you don't have the inhibition of the platelet activity, what will happen is that all those platelets will aggregate and adhere to the stent right away. And we sometimes see this right in the cath lab. So, so that is what really where the benefit is. And I'm forgetting the name of that. Is it adhere? It starts with an A, advance or something like that. Trial where they looked at this. It was published in NEGM. Maybe I can find it. They found that there were 8 stent thromboses in the arm where it was delayed versus the arm that received it within within couple of hours of activation. And average time of giving or the load was actually within 32 minutes to 60 minutes, like within an hour. What what this upstream registry is, it's actually loading 4 hours before the procedure, which is interesting because you're artificially changing the time. If you load earlier, it will be in the system by 2 to 4 hours, right?
Mm-hmm.
So if you're waiting for, in clinically, we are not waiting for these patients for 2 to 4 hours. So, but it's, I think in that registry, they wait before they do the cath. So you will see a difference if you wait. So if it all depends on how quick the patient reaches the cath lab. I am more of a Prasugrel group now because I don't know if you followed this recent study.
About a year ago, Prasugrel versus Ticagrelor.
Yeah, they compared with Ticagrelor in a STEMI study and found that actually it was better. Ticagrelor was better than, Prasugrel was better. And its name is ICER React 5 trial, I think so, right?
Yeah.
And they found it was superior. So I've started doing a lot more Prasugrel, especially in younger patients. In older patients, I'm more of a Plavix fan above 75 years of age. And that's again, was another trial. But superiority is something that it's really changed my practice. Although it will hopefully will change the practice in other people later, especially diabetic patients, younger patients, I give them Prasugrel. And with the Prasugrel, the difference is that you load them after you look at the anatomy. That was the trial design. With Ticagrelor, it wasn't. So they have not really tested Prasugrel, giving Prasugrel and then doing the cath afterwards. And I think the part of that was because the risk of bleeding is high. So if you load everybody with Prasugrel and then bring them to the cath lab, some of them will not get a stent. So they'll bleed. Mm-hmm. So your outcome will be looking worse because if they're bleeding. So, so I think that might be part of the decision making why they chose that design. But Ticagrelor, they did load, and recently I think you might have seen FDA has approved the use of Ticagrelor for primary prevention based on that trial. That Plato trial has really helped Ticagrelor grow. But definitely read ICER React, ISAR React 5 trial. And
I think, practically, I think when we're on for weekends or whatever, like when we're waiting potentially 48 hours and someone comes in with an NSTEMI, there's always a question, oh, should we load? Should we not load? And then there's, this is kind of regarding anticoagulation, but should they be on an ox versus heparin?
I would,
they're still having chest pain, should be considered bival, that sort of thing.
It's a very good question, actually. And if a center can afford Cangrelor, that's the best drug for these patients who are you waiting on. But if not, then I would load them. And especially if they're higher risk patients, I would load them if you're waiting. Because if they end up requiring cabbage, really the cabbage risk is mainly related to not waiting, but to the bleeding risk. So the enemy there is I understand is bleeding, but if you wait on these patients, which we do all the time in these cabbage patients, it will increase the cost of hospitalization, which I don't know if we can balance it with Cangrelor cost. But waiting will not really kill those people, If they're already waiting for 3 days, and STEMI patients, waiting for 3-4 more days wouldn't really kill them. But I don't know the answer to that. That what's the best answer? What to do over the weekends? So I personally like to load them. If you take my take.
You like using Anox over heparin in those situations as well?
The enoxaparin trials, the Essence 11B beta B trial, looked at this, and they found that if you're going for a conservative strategy, Lovenox or enoxaparin is better than IV heparin, which conservative strategy means no stenting, no PCI.
Stenting, yeah.
But otherwise,
Heparin's
it's better to give heparin. The reason for that is that enoxaparin, number one, people are not really comfortable in using enoxaparin for the PCI because the enoxaparin levels, you should monitor factor 10A levels. Okay, we don't do them. If you're not doing them, and there have been cases in our cath lab where the patient came in with enoxaparin and then you're told to give 0.3 milligrams of enoxaparin if it's within 8 hours of that, and that does not provide enough anticoagulation. So what happened is that there were acute stent thrombosis in those patients or thrombus formation. So if it's just one dose, you can just convert to IV heparin. If you're going for invasive strategy, I would still recommend heparin in those patients.
Makes sense.
Okay. Any other questions?
Do you ever use anticoagulants as anti-anginals? I think.
Oh yeah, that's an old paradigm.
Yeah, it's an old paradigm.
And it's still actually in the boards and in the guidelines, it is there that if you have ongoing chest pain with NSTEMI, it's not a STEMI, to use GP2B3A inhibitors. And I do use them rarely. I would say rarely. I have used them rarely. So if somebody, I mean, the best treatment is just do the cath.
Yeah.
But if for somehow you cannot do the cath because you are busy in another lab, then yes, you can try it. But you are really risking the patient to develop intracranial bleeding. The risk is less than is a 1%, but I think it's higher when you have like Ticagrelor on board and patient is already frail. And I try not to do that. But yes, if somebody has ongoing pain, yes, you should. That's one of the, if it comes on the options, that's the answer. Any other? What about the first years? You have seen some MIs, right? Ask questions about antiplatelets because not everything is available in the slides. They are not even listening. Are they listening? I'm going to ask the names. Aaron. Aaron. Is this Aaron? I'm going to unmute him. Is A, so he's going to show up the first. He's not getting unmuted. Okay, next is Brian.
Yeah, I'm here.
Okay, tell me or not tell me.
Well,
ask
I guess
a question.
I guess maybe this is a simple question or an elementary question.
That's fine. You have to ask a simple question.
So obviously we use Ticagrelor a lot. We use Plavix a lot. I know Prasugrel has the higher risk of bleeding, but what are some of the situations, or what's a situation where you would opt for Prasugrel over Ticagrelor?
So
assuming it's like low bleeding risk patient.
Low risk, yeah. So I touched upon that. So I prefer patients with diabetes. So in diabetics, it has shown to be a little bit more benefit compared to the non-diabetic patients. The second would be if I'm putting like 2 or 3 stents, multiple stents in there, multi-vessel PCI, I'll prefer to use Prasugrel. Then the third would be patients who are low risk of bleeding, like you mentioned. The fourth would be younger patients, so below the age of 65 ideally. even though the trial was 70, I'd like to see somebody in 50s, 40s, 60s to think about putting that patient on Prasugrel. And then the last group is the one that if somebody has a known documented Clopidogrel resistance, like you put that patient on Clopidogrel and you check their the PRU, the platelet reactivity units, and those units are still above 220. So that patient, you need to convert it to either Ticagrelor or Prasugrel. I tend to convert it to Prasugrel. So these 5 groups, I would say, I would think about putting these patients on Prasugrel. And then the 6th one, the trial I talked about, ISL React, the patients with STEMI who are coming in and they are not loaded, I'll prefer to use Prasugrel, which we can always convert to Plavix afterwards. But for the first day, when the risk of stent thrombosis is highest, I like to do Prasugrel in those patients. Okay. That's a very good question, not a simple question. Who's next? Fahad, you're interested in cardiology, right? So, eye on you. Where is he? Cannot be unmuted. Okay. Next is Josiah.
So I'm here with Brian as well. So I think you kind of alluded to, the question of loading or not loading. Are there any things that we should look out for so that we, I guess, not load in case, I guess, we anticipate someone might need a cabbage or anything like that in like the near future?
So the default practice at the moment in most interventionalists is to load. Okay. In private practice, and like I've worked in a few places before, they wouldn't load. And the reason for that is that patient might be going for cabbage. So people have come up with these arbitrary scores that if somebody's a smoker, somebody's diabetic, somebody has a low EF and large area of ischemia, that is likely going to have multivessel disease. So why just don't load those patients? But if you ask interventionists, they load them regardless of whatever it is. Okay, and then they think about that later on. So the current guidelines are not very clear about it, but Europeans are always ahead of us in that term, and they suggest loading in all the patients. So you should just load them. I did have a few cases where I was like, should not have loaded this. For example, one patient came in ventricular septal rupture, late presenting MI. Yes, that patient, you shouldn't be loading it, okay? Because if the patient goes for repair and it's not a cabbage is much less bleeding. The repair, you are opening up the heart, they're gonna bleed more, okay? So if the patient is late presenting, sure, you wouldn't load them in those cases because you might end up needing a different type of surgery, and that wouldn't be really good, or emergent surgery. Patient coming in with cardiogenic shock, they're not going to get surgery because of their risk, so just load them. The default should be load them, okay? Now, what's the best drug to load? Ticagrelor or Ticagrelor. That's the only drug, okay, to load. Plavix, if you're loading 15 hours before coming into the procedure, yes, it works. If you load it 1 hour before, it's not going to work. Okay, so it doesn't really matter. You load it or not load it. But if you put that on board Plavix, then the person will end up not getting any surgery. So the only drug I would say you should load is Ticagrelor. Okay, the other drugs, Prasugrel, you have to see the anatomy first, get an angiogram first, and then load. And the Ticagrelor, the Plavix, loaded 2 days earlier, 15 hours earlier. If you can do that, sure, you can. Like if somebody is coming for a planned PCI, there's a PCI already planned, you can load them with Plavix a day earlier, and that will be fine. But coming in with the ACS symptoms and ACS presentation, just load with Ticagrelor. What else?
Thank you.
Marisa. Okay, cannot unmute these people. Okay. Summer, oh, Summer came from her lecture.
Yes,
What?
they gave us a break from 12 to 1 for lunch.
You,
So,
you decided to come for another lecture. Good.
so I came in for another lecture, exactly.
That is the
Can't get
spirit.
enough.
Okay, so what is, ask a question about DAPT, dual antiplatelet therapy. Nobody spoke about allergies, so I did not talk about the allergies. You know, there aspirin allergy and there's allergies about. But you have a question? I'll talk about it. I always keep something.
I guess the whole the protocol for the aspirin allergy has changed. Before we used to say that you go to the cath lab, then they do the desensitization afterwards, and sometimes you do the desensitization, then you go to the cath lab. Do you have any preference? Is there any situations where you would rather do one than the other?
So I personally am scared of GP2B, 2B3A inhibitors. Okay, so the first category where you do the cath and then put and do the desensitization, the issue for me is that you are putting the patient on a drip, which is extremely potent platelet inhibitor, and they may bleed on it. Okay, and then you are desensitizing afterwards. However, the allergists have a different take on this. They say if you put somebody on an aspirin and they have an allergic reaction, they can develop worsening of the MI. So that's why they prefer the patient gets the PCI done first and then be put on aspirin afterwards. Regardless, whatever is feasible, you should go ahead with it. I have started doing this, the first one where you put the GP2B3 on and then desensitize later because it's easier to do in our setting. But you can go either way. It's more expensive to put GP2B3 inhibitor first and then desensitize. This is more expensive. But then you are balancing it with putting the patient in the ICU first to desensitize as well. You can do the GP2B3A even in step down and in short stay, and then desensitize.
Would you do G2B3A along with a P2Y12 like a Ticagrelor?
Yes, that's what the protocol is at the moment, and that increases the risk of bleeding really, really high. So in those patients, I wouldn't do Ticagrelor. I would just do Plavix.
Okay, sounds.
Okay. Yeah, so desensitization protocols are different. There, some places they do 2-hour protocols, some places they do 4 hours, some places they do 6 hours. Mainly, what you really need to know is that you have to have an allergist involved, and what they do is they give very small doses of aspirin and see how it does. So you start with a 1 milligram or a 5 milligram dose, and then the quick version I can tell you, you give 10 milligram, 20, 40, 100, something like that. Okay, so we have 81 milligrams, so you can divide it into like almost fifth of that, I guess, and start from there and go up. That's what they're doing every 30 minutes and observing the patient for any breathing difficulty or any form of hemodynamic instability. Okay.
Okay, makes sense.
All right. So, anything else? Any other questions or? All right. So it's 12:58. Thank you very much for joining. And if you have any feedback, let me know. Okay. Thank you. Bye. I'll record this and post it on YouTube for the other people. Thank you. Thank you, Chiefs.
Thank you.
Bye.
Bye.